Hello, my name is Bryant Lin. I'm co-director of the Center for Asian Health Research and Education. I would like to welcome you to the next in our series of talks on Asian health issues and health in general. We're happy to welcome Dr. Joshua Spin today, who will be talking about the abdominal aortic aneurysm, the search for therapies. Joshua Spin, MD, PhD, is a clinical associate professor of cardiology at Stanford University and a staff cardiologist at the Palo Alto VA. In addition to his clinical work at Stanford Hospital and the VA, he is a member of the Stanford Center for Inherited Cardiovascular Disease and the Stanford Cardiovascular Institute, and is also an attending physician in the Stanford Marfan Center. Dr. Spin's laboratory conducts basic and translational research in vascular biology with an emphasis on investigations of abdominal aortic aneurysm and vascular smooth muscle cells. Before we welcome Dr. Spin, I would also like to wish all of you a happy Lunar New Year. I think our next talk will be on February 22nd, so this is our last talk before the Lunar New Year, the Year of the Tiger. So welcome, Happy New Year, and would like to welcome Dr. Spin.
Thanks very much for that introduction. Good evening. My name is Josh Spin. I'm a cardiologist at Stanford and at the VA, and a cardiovascular researcher in a shared lab with my collaborator, Phil Zhao, at the Palo Alto VA. And I'd like to start by thanking the Center for Asian Health Research and Education and the Vincent Wu Memorial Foundation for giving me the opportunity to speak today. I have no disclosures. So we're going to talk today about abdominal aortic aneurysm. We're going to talk about what it is. We're going to talk about what causes it. We're going to talk about how it's treated. We're going to also get into some detail about how smoking and nicotine are related to AAA. And we'll also talk about how we in our lab approach the search for new treatments and what are some treatments that we're investigating that are potentially going to show some promise down the line. So let's start off actually with kind of the most obvious question, which is what is the aorta? The aorta is the largest artery in the body. It's an elastic artery, so it has a lot of elastic tissue and elastic fibers built into the wall. It comes directly out of the heart above what's called the aortic valve, and it ultimately supplies every organ in the body via its arterial branches. It's subject to some of the largest vessel pressure fluctuations because of being just outside the heart. And it's designed because of its elastic tissue to rebound and deflect the pressure waves downstream. The wall is made up of multiple layers. It has the lumen in the middle here. This is where the blood is flowing. And the intima is a single layer of endothelial cells, which is around the inside here. Then there's the media, which is a thick layer of smooth muscle cells that has elastic tissue and extracellular matrix in between. And the whole thing is surrounded by what's called the adventitia. This is a layer of fibroblast cells, which make collagen and other types of connective tissue of connective tissue, and offers supporting elements to help hold the whole thing together. So then the next question, of course, is what is an aortic aneurysm? So one thing that's very important to know about aortic aneurysm is that it can occur pretty much anywhere in the aorta. And the definition of an aneurysm is something that bulges beyond 50% above the normal diameter. Now, the normal diameter varies. It depends on the age of the person. Older people have bigger aortas. The patient's size, if you're bigger, you have a larger aorta. And the anatomic location, because the aorta starts at its largest, and then as it gives off side branches all the way down to the legs, it gets smaller as it goes. So aneurysms, as I say, can occur anywhere. In my other life with my other hat, I work in the Stanford Marfan Center, and patients with Marfan syndrome develop aortic aneurysms in the root, and you can see that right here, which is the area just above the aortic valve. Aneurysms associated with high blood pressure and with things like a bicuspid aortic valve, which is a valve that has only 2 leaflets that people are born with, can end up leading to aneurysms inside the ascending aorta. And then once you get over on the downside, people can also develop aneurysms in the descending, which you see over here. And then mostly what we're going to be talking about today is aneurysms that occur in the abdominal aorta, which is this area down in the belly, and specifically below the vessels that go to the kidneys, the so-called renal arteries, and the iliacs, which are these main vessels down here in the pelvis that ultimately go down to the legs. And this is an example of what an abdominal aortic aneurysm looks like on a CT scan. So why do we care? What is the big deal with abdominal aortic aneurysm? So the answer is it's a very significant cause of morbidity and mortality. It causes approximately 10,000 deaths, about 84,000 hospitalizations annually in the US, and require about 34,500 endovascular and open repairs to fix them annually in the US. There's also about 200,000 deaths estimated worldwide due to AAA. While the prevalence does seem to be falling over time, in men over 65, it dropped from 5% to 2% in high-income countries over the last 20 years. The global death rate is actually up about 12% over that same time frame. About 50 to 70% of people who have a AAA ultimately end up needing to have it repaired. That usually occurs at certain set cutoffs, usually 55 millimeters in men and 50 millimeters in women. And crucially, as mentioned here on the slide, there are no current medicine-based treatments, only surgical treatments. So let's go into some more details about AAA. One of them is that it is a common problem of the elderly. In general, young people don't get these. It can happen, but if it does, you probably have a connective tissue disease underlying it in some way. It starts to occur, generally speaking, about age 50 and then goes up with age. And if you think of aneurysms that are associated with kind of all the classic risk factors of atherosclerosis, of high cholesterol and high blood pressure and that kind of thing, 75% of all the aneurysms that occur in that background occur as AAAs. Almost all of them are below the kidneys, as I mentioned, in the infrarenal area, almost 95% of them. One question that was asked in the pre-survey was related to gender and genetic predisposition. And the answer is there's actually a very large gender and genetic disparity. Men develop these 9 times more often than women do. And if there is a history in your family of having a AAA, especially in males, there's almost a 12-fold increased odds of you having one. The risk factors for AAA are ones that you would pretty much consider, being male, being older. Smoking is very important, and we'll talk about that more a little bit later. Having high cholesterol, and as I mentioned, a family history. Interestingly, not diabetes. Diabetes is actually considered to be a negative risk factor, despite all of the correlations with all of the other conditions, possibly due to thickening of the aortic wall, which may slow growth down. And there's some active research in this area that has been going on. Often there is a blood clot inside the aneurysm, sort of layered on the wall, which we think is at least in part related to disrupted flow. Until they cause a real problem, until they, the disaster occurs, they're usually not symptomatic. They rarely rupture or tear if they're less than 5 centimeters in size. But if they start growing rapidly, that does suggest a higher risk of rupture. And so once they're identified, they need to be followed over time. How are they diagnosed? Well, honestly, they're often found incidentally. Somebody is doing an ultrasound or a CT or an MRI for some other reason, and they happen to spot it. It is rarely able to be felt, mostly because of its location, which is back of the belly button and all the way in the back. It actually runs against the back. So for it to get big enough to feel in front is often quite difficult. And as mentioned, there is currently no effective medical therapy. And so what you're left with is needing to repair it once it gets to a big enough size. So why are they dangerous? Well, in addition to the abdominal pain that they can cause as they start to become unstable, and usually, as I say, they don't cause that when they're not unstable, they can cause what's called atheroembolisms, where cholesterol and clot can move downstream to smaller vessels down below, in the feet, for example, and block off small arteries, sometimes causing real trouble. The big concern, of course, the disaster everybody's afraid of with these is rupture. Rarely do they just tear the wall the way you sometimes see in aneurysms in the chest, but instead they actually tend to rupture, and it can be quite sudden. Some danger signs are if the mass is tender, if it's painful, if it's accompanied by low blood pressure. And off to the side here, you can actually see an example of one that did just that. The mortality associated with something like this, there are a lot of estimates you'll see in the literature, and they kind of range all over the place, but typically it's somewhere between 40 and 70% if it occurs. And you can imagine why, it being the biggest artery in the body, if it actually ruptures, it doesn't take very long for things to go very badly. The repair used to be pretty much restricted to what we would call open repair, which is what you see here, where you clamp off the lower vessels and then stitch in a piece of Dacron into the middle to exclude the aneurysm. And this is very effective. It works very well. The problem is, as I say, the aorta runs down the back, and it's a fairly morbid surgery. It takes a long time to recover from. There are a lot of risks associated with it. And so nowadays, more and more people are going with what are called endovascular stent grafts, which are these grafts that are placed just below the kidney vessels, and they try to anchor it in place here and then extend it down into the iliacs, which are these vessels down into the legs. There are a number of issues with this. One is that sometimes there's not a whole lot of room for them to be deployed right underneath the kidney vessels. The other is that the aneurysm often goes, right up towards it, and the aneurysms continue to grow once the graft is in place. Those same processes that made it happen to begin with are often continuing. And so after a while, they start to get large enough that the stent graft no longer is up against the wall, and they get what you call endoleaks. And then you actually have blood flow continuing into the aneurysm. If it does continue to grow, it may worsen to the point that it may require open repair. So what about medical therapies? What have we tried so far? And unfortunately, the lack of an effective drug therapy is a pretty big deal for this particular problem. There have been 11 randomized controlled clinical trials to slow AAA to date, and they've included things like blood pressure medicines like beta blockers, and ACE inhibitors and calcium channel blockers. And while there's been a little bit of benefit, for the most part, nothing has really reached significance. They've tried fibrates for cholesterol lowering. They've tried antibiotics. Initially, the thought was, just as a side point, there's one school of thinking that one of the things that causes vascular inflammation is a bacteria called C. pneumonia. And the thought was that if you used antibiotics to treat that, it might help. And then later trials of an antibiotic called doxycycline, that was being used because it actually decreases matrix breakdown. It can keep elastic tissue intact. Unfortunately, as you can see over here, in favors placebo this way, in favors intervention, it comes right dead center because none of them work. They've tried inhibiting mast cells, which are a special kind of white cell. They've tried using antiplatelet agents, and again, not so far efficacious. But others are underway. There are other trials and other medicines that are currently being explored, and that's part of why we're doing what we're doing. So one of the things that's very important about understanding AAA is really trying to figure out what's wrong down at the cellular and tissue level. What occurs that ends up leading from normal tissue over to aneurysmal tissue. The endothelial cells on the inside get damaged and go missing. The elastic tissue out here that's supposed to be supporting the smooth muscle cells degrades and fragments and comes apart. The smooth muscles themselves die off and disappear, thinning the wall. you get infiltration of different types of immune cells, like T cells, and especially monocytes and macrophages. And then, as mentioned, you can sometimes form a clot on the interior surface. And in addition to the fact that that causes inflammation, it also blocks off oxygen flow to the aortic wall, which can cause more damage. So we're going to take a short diversion here to talk about smoking, which is going to come up again later, but I really want to make a point about smoking and AAA and also nicotine. So smoking is by far the strongest modifiable risk factor for AAA. Almost 90% of patients who have AAA have smoked or are smoking. Only lung cancer actually has a stronger association with the disease, between, I should say, smoking and a disease. In fact, if you think about medical therapies, well, the only therapy known to decrease the expansion rate of AAA is to stop smoking. That actually works fairly well. There are numerous proposed mechanisms as to how smoking affects AAA formation, but I also want to talk a bit about nicotine, which is the addictive major component of tobacco smoke, as folks know. Substantial data supports that it has a role in vascular inflammation. And specifically, it turns up the stiffness of the aorta. And if you use it in mice, for example, you find that the aorta gets progressively stiffer, and that then predisposes to abdominal aortic aneurysm. Work out of our lab shows that. And then we've also shown that if you either infuse or if you vape nicotine in the form of an e-cig, an e-cigarette, that also augments murine model abdominal aortic aneurysm. In addition, and this is in some ways even more troubling, we all know that toxins of various kinds can alter the DNA, and these are called epigenetic modifications. DNA methylation, for example, if you add a methyl group to your DNA bases, it can either silence or activate genes depending on where it winds up. And these changes can actually be durable across generations. And cigarette smoke and nicotine are both very strong modulators of DNA methylation. In fact, if you have smoking prenatally, that can alter DNA methylation in the offspring in a way that persists all the way to adulthood. And those variations in human cord blood actually correlate with cotinine, which is a metabolite of nicotine. Thousands of these differentially methylated regions are found in human blood in smokers versus non-smokers. And while most of them do revert with stopping smoking, some of them are durable for up to 30 years. Nicotine itself can pass through the placenta and alter DNA. And in rat experiments, they found that if you expose mice through their mothers, it actually induces risk for asthma, not only in their children, but in their grandchildren. Leads to durable changes in DNA methylation in the ovary, in the testis, in the lung, and also in the aorta, where it alters vascular contractility, it alters how the vessel can contract and relax. It heightens oxidative stress, which leads to vascular inflammation, and it increases the aortic response to a hormone called angiotensin II, which is part of the process of high blood pressure. So this is the approach that our laboratory has taken to working on AAA, and this is fairly typical, I think, for many translational labs. We start off looking at animal models of the disease. We then identify candidates to potentially modify or work on. We verify those mechanisms as to how they're actually functioning in vitro in cell cultures and in petri dishes, and then move on to test our hypotheses in the animal models. And then we check to see if there's real translational potential. Is this something that we might really be able to take into people? As most folks know, animal models are a bit of a flawed mirror. We certainly rely on them a great deal in this case. Their advantages are many. They closely mimic human physiology. They're living organisms which enable us to explore the pathophysiology of the disease. They develop abdominal aortic aneurysm very quickly, and they have whole tissue effects instead of just their cells, which allows us to test the therapies and hypotheses that we're interested in. There are, of course, some disadvantages. One of them is that the animals are typically pretty small. They're usually mice. and they have somewhat different anatomy and physiology than people. They're also horizontal creatures, unlike ourselves, and so they have slightly different physics in terms of their blood flow. The fact that they develop it quickly may not be our friend. AAA takes years to develop in humans. Also, drugs may have different effects in animals than in people, and protein molecules and genetic pathways can work somewhat differently or have different structures in animals than in people. I want to just call attention to two models which we tend to use in our research. One of them is the APOE mouse, which is a high cholesterol mouse, and we infuse through a pump angiotensin II, which is the hormone I was talking about, and that leads to aneurysm formation. The other one that we often use is called the elastase model, or porcine pancreatic elastase, PPE is another word, where we infuse elastase directly into the infrarenal aorta, causing an aneurysm to occur. Just to kind of focus on these a little bit more, this is the angiotensin II APOE mouse model. There are many pros. It's technically very simple. You basically put in the pump, and within a few weeks, you have an aneurysm. It's very reproducible. It has human-like pathophysiology. It has pretty high incidence, at least in males. It tends not to so much in females. The cons are that it's a dissection model or a tearing model. You can actually see a little flap here that forms where the vessel tears a little bit, which then allows it to weaken and grow. And the other disadvantage is, maybe you can see over here, here are the kidney vessels, and here's the aneurysm above it. So in this model, the aneurysm naturally forms above the kidneys, which is different than people. Down below here, you can see what it looks like for a control mouse who's been given saline as opposed to one who's been given angiotensin in terms of their aortic size over the course of 4 weeks. Another model that I mentioned was the PPE model, the elastase model. This one is entirely infrarenal because, of course, we're injecting into the infrarenal area. It has 100% incidence, so you're going to get an aneurysm every time. The pathology really looks very much like what happens in human tissue. The cons are it's quite hard to do. You really need to be a skilled vascular surgeon to pull this off, and it takes months to learn how. And there are no aspects of kind of high cholesterol or high blood pressure the way there are in people. Again, one other upside though, which is that it recapitulates the risk profiles of people. If you look down below here, here's saline, here's the protected group of diabetics, females, and then males, and then aged males, and then nicotine exposed males. And you can see that the rate at which their aortas grow very much reflects the risk you see in people. So what are some approaches that we've tried? So this is different work from our lab, and I apologize if some of these are kind of complicated. And I've listed some of the publications that we've done to look at some of these. One thought would be to reduce the pressure differential between the top part of the aorta and the bottom part. The explanation behind this is that having differential pressure above and below seems to be one of those things that stimulates aneurysm formation, where the stiffness is different in one spot than in the other spot. And so you can simulate that by increasing blood pressure, for example. It brings out that stiffness and the increased strain that occurs in this region where the aneurysm forms. And so one approach is just to coat it with glue. We have a particular kind of biologically safe glue called BioGlue. And if you strengthen it with the BioGlue, it actually seals it up very nicely, and then the aneurysm doesn't form. This is something that wouldn't be particularly complicated to do, apart from the fact that you've got to open somebody up to do it. So maybe this is something that we're still kind of thinking about how this would translate to humans. This is a fairly complicated slide, and I will try to be as simple about it as I can. We've done a lot of work looking at what are called microRNAs. These are tiny little non-coding RNAs whose job it is to regulate many, many genes at once, not through the interactions with the DNA, but through interactions with mRNA, so messenger RNA. You can also use long non-coding RNAs, which are in many ways similar, just much, much bigger. And these molecules are used by the body to fine-tune gene expression for hundreds of different genes all at the same time. You can alter entire gene pathways and responses in a comprehensive way with these things. And so here is, just as an example, here is a mouse that's what we call a sham mouse. This is a mouse who's had an operation, but nothing has been injected. Here's a mouse that's received elastase and a scrambled microRNA. So this is what would happen typically in the model. So scrambled is in the middle here. And then here's one where we've used a molecule to turn down microRNA 24, which, as you can see, leads to considerably bigger growth. And here's pre-24, where we've overexpressed microRNA 24, and it tends to cause the aneurysms to be smaller. MicroRNA 24 happens to regulate cellular inflammation and vascular inflammation, among other things. So there are problems with using these molecules systemically, meaning if you inject it and then you let it go all over the body, they can potentially fine-tune that gene expression anywhere in the body that they wind up. As noted, abdominal aortic aneurysm is a localized condition, so treatments either need to be delivered locally, they need to home into the site, or they need to be systemically beneficial, or at least not harmful. One example is microRNA 29B, which we were very interested in. It is great in helping to strengthen the aortic wall through overexpression of collagens and supporting molecules. But then if it gets into other organs, it can cause overgrowth and fibrosis of connective tissue in other places like the kidney, the liver, the heart, and the lung, which you can imagine is very problematic and not something you want to see. So the key to this particular translation and getting it into people is going to be local delivery if we can manage it. Here's some additional approaches that we've tried. We've used stem cells. We've tried creating a porous scaffold and then allowing stem cells and smooth muscle cells into them, and then putting it over the aneurysm in the mice, and then putting a little cover over it and seeing whether the cells will migrate into the tissue and help restore the aorta. And we did have some success with this, mostly with the smooth muscle cells, actually, as opposed to stem cells that were differentiated into smooth muscle cells. And at the top here, you can see this is what happens if you just put the scaffold on it with no cells in it. So they were definitely doing better if they got smooth muscle cells. And they did live for a certain amount of time. The biggest issue with this particular approach is getting the cells to survive for a significant period of time and really home in and support the aorta. So how do we move from the biology? So we're doing a lot of studying on the biology here. How do we move from that to drug therapy and trying to find something that we can use in that way? So I'm going to tell a little story here. We're going to start off talking about nicotine. So as you remember, treating mice with nicotine increases the severity of AAA in the mice themselves. But we also found, and this is a recent area of study for me, that it also increases the severity of abdominal aortic aneurysm in their offspring. Here's what happens if you give the mothers nicotine as opposed to saline in their offspring's aneurysms. And here in the males up at the top and in the females down here at the bottom. It increases the rupture rate if the father's got nicotine. Here, increasing the incidence in the males if the mother's got nicotine. So the severity and the rupture rate and the size all get worse in the offspring if you give the parents nicotine. And I should mention that this is not in utero. For the males, certainly not, but in the females, this was actually given and then stopped, and then they mated. So this is actually effects happening after that. So we got curious as to what was going on here and why this was happening. And we found that treating the parents with nicotine alters the aortic DNA of the offspring. And we did some analysis of the locations where this was happening. And lo and behold, a large number of them were actually in areas related to DNA transcription, and especially transcription factors. These are factors that are found in every cell in the body that bind to DNA and activate it to tell it to start transcribing a gene. So given that we have these modified transcription factors, the question then is, well, which ones might be contributing to abdominal aortic aneurysm? So we have a software tool that we can use that actually predicts, if you have a list of genes, you can predict which transcription factors target them. And then we looked at the gene expression in the mice that went up and down with aneurysm and identified a particular transcription factor that was present on both lists, specifically one called ERF8. Okay, so ERF8, well, what's that? Well, ERFs are interferon response factors. These are transcription factors that activate genes in response to something called gamma interferon, which is a signaling molecule for the immune system. And ERF8 is expressed in lots of different cells, immune cells, and stressed smooth muscle cells. It's very important for turning on monocytes and macrophages, which all of which are key cells in AAA. And they can regulate smooth muscle cell structure, function, and death. Well, gee, that sounds an awful lot like a lot of the processes that are important for AAA formation. And in fact, if you look in the toxicogenomics database, lo and behold, there's tobacco smoke as a known interactor with ERF8 that is thought to regulate it. And they actually did a study looking at human monocytes exposed to smoke, and lo and behold, a lot of the interferon ERF8 responsive genes all increased. So then the question is, all right, so if we've identified ERF8 as a potential handle that we might be able to use to modify AAA, what then do we do about trying to get it down? So we think about what drugs might downregulate it. So there's a database that contains expression profiles from different cells that were perturbed by thousands of different compounds. And we find, if we kind of go through the list, a chemical called securinine. This is also high on the list for chemicals that alter AAA-related genes from our data, or I should say are predicted to alter AAA-related genes. So that brings up the question, well, okay, well, where's securinine? So this is actually how the link into the seed grant that we got from CARE fits in here. Securinine is one of the 50 fundamental traditional Chinese herbal remedies. It's an alkaloid found in some shrubs, and it has been used in Chinese medicine with some efficacy in neurological disorders like ALS and Parkinson's disease, Alzheimer's, and polio. And it's even thought to be helpful in colon cancer and acute leukemia. And it has some neurological anti-inflammatory properties, suggesting it might also have some vascular anti-inflammatory properties. However, one kind of warning, and this is going to again come up later, it's an alkaloid that actually promotes seizures if too much of it is used. So as part of our studies, we tried out what happens if you expose cells to securinine and found that smooth muscle cells and monocytes both have ERF8 and different inflammatory markers that are important turned down if they're treated with securinine as opposed to a control vehicle. It also reduces the key AAA inflammatory gene, interleukin-6, in those macrophages compared with nicotine. So here you see nicotine increasing IL-6 levels. And here you see if you add securinine, you remove the effects of nicotine and reduce IL-6 levels. And here's kind of the proof of the pudding. We tried giving mice who we had induced AAAs in using the PPE model. They got either DMSO, which is the vehicle that the securinine is dissolved in, or they got securinine injections, or they got just DMSO, or they got nothing. And you can see here there was substantial reduction in the size and progression of the abdominal aortic aneurysms when they were given securinine. Also, if you looked in the mouse tissue afterwards to see what had happened, you found that there was reduction in gene expression for aortic inflammation, like macrophage markers, And also ERF8, as expected, turned nicely down, as was interferon gamma, using security. Unfortunately, some issues remain. As I mentioned, security is a bit of a problem with regard to seizures. In fact, several mice died during the project due to seizures. And this was a frequent issue during treatments. And so the key is to find a dose and a regimen that will be effective on AAA, but without causing these side effects. It would also, of course, help once we found that dose to then confirm it with trials in other abdominal aortic aneurysm models. Or alternatively, we can try to find other candidate drugs that might affect ERF8 and have similar effects on AAA, but without that proconvulsant downside. Once you establish efficacy and safety, you can start thinking about larger mammal trials like mini pigs, and then maybe on eventually to humans. So in conclusion, abdominal aortic aneurysm really remains a vascular scourge that has no medical treatments. Smoking and likely vaping as well not only increases the risk of AAA, but may also increase disease risk for it in future generations. Numerous different approaches are being studied, and some difficulties include differences between humans and animal models, the delivery methods, side effects, and especially efficacy. Doxycycline, for example, worked great in mice and again, didn't really seem to help in humans. So the hope is that we'll be able to get efficacy in human trials. And support from research institutes and groups like CARE will be crucial for future success going forward. I want to just highlight here our other funding from some other sources, and also our really terrific collaborators who have helped us along with some of these studies, and the wonderful postdocs and techs in the combined SpinZao labs. And I thank you very much for your attention, and I will take questions.
Great. Thank you so much, Dr. Spin, for an excellent talk. And but I'd like to, again, thank the Health Library for co-hosting these talks, as well as, of course, in partnership with our organization, the Center for Asian Health Research and Education. And this series is sponsored by the Vincent V.C. Wu Memorial Foundation. We have a question from the audience. Is secondhand smoke a factor? Being a boomer, most of my parents' generation smoked.
Yeah, so that is an excellent question, and it's entirely possible that secondhand smoking may be a significant issue. I will say that at least in the studies that I've seen, secondhand smoke is capable of altering DNA. The risk for abdominal aortic aneurysm is not super clear. I share your concerns. I grew up with a smoking parent as well, there is some thought that it might end up leading to increased risk over time. It's not clear really how severe that risk is, though.
Great, thank you. And just a reminder to the audience, please submit your questions in the Q&A, and we'll try to get to them. From our next question from the audience is RNA therapy, is the RNA therapy that you mentioned still in active research? What are some of the strategies for local delivery of RNA therapy in AAA?
Right. So this is a terrific question because, as you may know, one of the primary places that RNA goes, if you, along with pretty much any other kind of gene or RNA therapy, is it winds up in the liver, which is, again, not a place you want fibrosis to be happening. So one thought that we're moving forward with, and we're doing some active testing along with our collaborators, especially Lars Magdefessel in Germany, is using drug-eluting balloons. The idea being that you would have a balloon that would be capable of eluting the microRNA, either mimic or inhibitor, directly into the wall. Maybe you could use a cocktail of inhibitors, and that way you would get direct exposure into the wall itself and avoid systemic exposure.
Great. Next question, I'm going to broaden this question. It says, the question is, does Nicorette constitute infused nicotine? So I guess broadly, our nicotine replacements, can they contribute to the same issue?
Yeah. So I personally have, based on my research thus far, I have a lot of concerns about nicotine replacement therapies. I suspect they're marginally safer than smoking itself. But I think the real key would be to transition to Nicorette or something similar, and then if possible, off it altogether. Because again, I think a lot of the health effects that we're seeing, especially for things like AAA, a lot of the effect may actually be coming from nicotine itself, and that really poses a problem for a lot of cessation issues. I mean, as you may know, that's really the argument behind vaping, was that it was supposed to replace smoking, and yet you get just as much or more nicotine from e-cig vaping as you do from cigarettes. And it looks like it's entirely possible that many of the risks that we see for vascular disease and other vascular conditions are going to be just as bad with vaping, or maybe even a little bit different. We'll have to see going forward. Part of the problem is because they're relatively new technologies, we haven't really had time to see how they're going to develop over many years. And because we know AAA takes decades to develop, it may be one of those things where we don't really see the impact for a long time, and then we're going to see a lot of it.
So bottom line, stop smoking. If you go to nicotine replacement, don't stay on that too long as well.
That would be my recommendation. Yeah.
Great. From another audience member, my father was diagnosed at 96 with AAA, didn't have treatment, died 18 months later. But not from AAA, not from the AAA itself. As a 70-year-old female, do I have a greater risk of developing a AAA?
Right. So the answer is yes, but it's probably not. As a female, it's going to be less. But in anybody who's got a parent who's been diagnosed with AAA, I pretty much always recommend that they be screened with an ultrasound. Just to make sure that they don't have one, especially as they're getting on in age. Of course,
what age do you think? What age? 65 to start screening if you're not a smoker, even?
Yeah, so 65 is kind of standard, especially for smokers or previous smokers. It obviously sort of depends on when the parent developed it. I mean, 96 that's up there a bit, but again, it doesn't surprise me that something else would have been the cause of demise, because it's, as I say, it does tend to take a long time to grow, and often you wouldn't do anything about it at that age, balancing the surgical risk against the risk of something going wrong while doing it.
Related to that question, this is a question for me. I frequently, as a primary care doctor, I see patients who say, we get the flag that says, oh, this patient has a history of smoking, you should screen for AAA. And then I counsel the patient, and the patient says, well, I only smoked for a couple of years, 40 years ago. Does that make a difference? Should I still be screened? So if they had a distant kind of short history of smoking, is there, is it really dose dependent, or there's a threshold effect? Should everyone really with the kind of remote history of smoking be screened?
Right, and that's an excellent question. My feeling about it is that ultrasounds are pretty benign. They do cost something, so there's that aspect. But I am pretty sure that it is at least somewhat dose dependent. The more smoking you have, the more years of doing it, the more you continue to do it as you get older, the higher the risk. But I think any smoking exposure could potentially set off something like this. And because they're so asymptomatic, it doesn't really pay to be surprised. So my tendency is that if there's a history of smoking anywhere, you just get the ultrasound. If they're negative at 65 and there's no sign of aneurysm at that point, you're probably okay, especially if they'd stopped smoking a long time ago. Could still develop one later, but odds are much lower.
The next question we have is a little bit related. I get this question in primary care a lot. A lot of times people say, oh, they saw on some sort of imaging that they have atherosclerosis in the abdominal aorta. Does that, need to be monitored? What's the next step with that?
Sure. So atherosclerosis in the aorta is actually a really good surrogate for vascular disease generally. It means that cholesterol buildup is taking place. It doesn't necessarily tell you, of course, where it's building up. You know, it could be building up in the neck vessels or in the heart vessels and in other locations. It's probably an indicator that your cholesterol could stand to be lowered to keep it from progressing in other locations. It doesn't necessarily prefigure developing an aneurysm, but could. And I think usually what I use the signs of atherosclerosis in the aorta as an excuse to do is to really start to work on those risk factors and get them down as much as possible. I would note that atherosclerosis in the aorta, unfortunately, is tremendously common. You know, there are studies of kids who, you know, died in Vietnam who were already showing atherosclerotic streaks in their aortas on autopsy, you know, kids in, you know, 19 and so forth. So it happens quickly, and especially on the so-called Western diet. And so just being aware that it's a very, very common finding.
Our next question is about younger people. Are there any groups of younger people who need to be screened for AAA? And then kind of a caveat from our viewer is, you know, a lot of people, especially who are thin, can feel a pulsating sensation of the abdomen. Should they be concerned about that?
Right. So it's a good question. I'll address the latter part first. So unfortunately, that kind of pulsatile sensation in the upper abdomen, especially when lying down or asleep or you know, getting ready to go to sleep, is fairly common. And I think it mostly has to do with the anatomy of the fact that the aorta is kind of right underneath the stomach, and the rest of the organs are kind of sitting on top of it. And so if it as the pulse takes place, it bounces, and you can kind of feel that sensation. I think that would be very high for a AAA to take place, and of course, it's extremely uncommon to occur in very young people. The only caveat to that is that if there is a history in the family of connective tissue disorder, things like Loeys-Dietz or Marfan syndrome or similar sorts of conditions, it is very important to monitor the vasculature generally, because aneurysms can form anywhere and at any age. Again, this particular kind of aneurysm, what we're thinking of is the atherosclerotic AAA. I won't say you never see it in 20-year-olds, but it's pretty vanishingly rare unless their cholesterol is super high for genetic reasons. People, for example, with familial hypercholesterolemia, whose cholesterol run really, really high, and who also, for example, smoke, could develop a AAA at a very young age.
Next question is there any correlation between, I'm assuming he means thoracic aortic aneurysm and abdominal aneurysm?
Right, so it does depend on where we're talking about. So in the ascending portion, those are typically associated with high blood pressure and with, as I mentioned, bicuspid aortic valve and Marfan syndrome and other causes like that. In the descending aorta on the backside, as it's coming down, you will often see aneurysms forming in that descending part in the chest. And those are thought of as, again, kind of atherosclerotic aneurysms. So those are much more closely related to the ones that you see down in the abdomen. And those can be quite dangerous. They don't tend to cause quite as much trouble as AAAs, but they can sometimes cause back pain. They can cause you can wind up with ulceration happening into small vessels that go to the spine, and that can be very dangerous. So yeah, they are connected, those two. And again, the same risk factors for AAA are also risk factors for descending thoracic aneurysms.
Great. Our next question, if there is no atherosclerosis abdominal aorta, but your cholesterol is high, total above 200, should I take a statin, and why?
Right. So this is sort of a general question, and it applies not only to AAA, but of course more broadly to coronary disease and other conditions like that. I'm a big believer in statins. As you can imagine, I take one myself, despite the fact that my cholesterol is basically normal. I'm one of those kind of folks who think they ought to be in the water. And actually, I'll take a brief diversion, if I may, which is that we had a talk from Eugene Braunwald, who's one of the founding parents of American cardiology, who pointed out that if you have a genetic condition that makes so that your cholesterol, your LDL cholesterol, is 60 or so from birth, which many people have, they literally never develop either coronary disease or strokes or any atherosclerosis at all. It just never appears. In comparison, almost everyone who has normal cholesterol develops atherosclerosis eventually. So it probably means that our definition of normal for cholesterol is too high. And so we have a tendency to pass over LDLs of 130 or 135 and say, oh, it's a little high, but not too bad. And the answer is that that's probably going to come back to bite people eventually. So to try to answer the question more specifically, it does depend on your risk. If you have other things, for example, being a smoker, being diabetic, having hypertension, having a family history, all of those things will tend to raise your risk and would suggest that your cholesterol really should be lower. If your total cholesterol is 200, again, it depends on the balance. If we're talking about high good cholesterol, high bad cholesterol, high triglycerides, the bad cholesterol and the triglycerides we think are more of a problem. But if there are people who have total cholesterols of 200 and almost all of it is HDL, and that's great. And no statins required there.
Great. I think that is it for our questions today. You've had a whole bunch and you answered them quite succinctly and in a very clear manner. So thank you so much, Dr. Spin, for joining us today. Really, and again, thanks to the Vincent Wood Foundation for sponsoring this talk. Happy New Year to the audience, Lunar New Year. Next month, we will have a talk on non-smoker lung cancer or never smoker lung cancer in women with speakers from UCSF. So thank you so much for joining us today. We hope you have a great week.